Hi, welcome. In this video, we will learn about newborn resuscitation. How to resuscitate a baby if the baby is not breathing at birth. So you should know that 90% of babies are born term and they are vigorous and may not need any assistance, or they may need some initial steps. Some assistance, that is initial steps. Now, around 10% of newborn babies require a higher degree of assistance, and that is to begin breathing at birth, such as bag and mask ventilation and oxygen, and maybe oxygen. So, less than 1% need advanced resuscitation like chest compression and medication. So, our target newborns are constitute around 10% of population. Now, this is the inverted pyramid, which shows on the upper side that most of the babies come where they don't need any assistance during breathing, and as the assistance, the amount of assistance is needed, the percentage of population gradually reduces. So, 90% may need no assistance or initial step, and 10% may need bag and mask ventilation without oxygen, and less than 1% need chest compression. Plus or minus antiviral injection. So this is the newborn resuscitation program, NRP in nutshell. So if the baby is not breathing, then you have 4 steps to follow. The first step is to manage the temperature and the airway, and second step is to manage the breathing, B for breathing, and third for C for circulation, and fourth D for drugs. So the first step, which is management of the temperature and airway, is called the initial step. So here, the baby is not breathing, you clamp and cut the umbilical cord immediately and bring the baby to the warmer and dry and stimulate and clear the airway if needed. Give warmth, keep the baby under warmer, dry and stimulate, clear the airway if needed, and position the baby. So this is called initial steps, and the initial steps usually should take only less than 30 seconds. Now, after initial steps, if the baby is not breathing, or if baby is gasping, or if the heart rate is less than 100, then you go for the second step, which is called the positive pressure ventilation or giving breathing. So after giving 30 seconds of effective ventilation and still the heart rate is less than 60 per minute, then you give chest compression, and chest compression is given at along with positive pressure ventilation at a ratio of 3:1 for around 60 seconds, and after 60 seconds of chest compression with positive pressure ventilation, if still the heart rate is less than 60 per minute, then you give adrenaline. That is the fourth step. Now, this is the flow chart which shows the entire newborn resuscitation program, which starts with the antenatal counseling, that is counseling the mother, especially if the mother is preterm, or the baby is going to be delivered at preterm gestation. Then debriefing the team, what the team should do and what they should expect and how they should perform, and equipment check. So, and then you go to the main thing, which is the initial step, then positive pressure ventilation, then chest compression, and then antiviral. So, the positive pressure, the perinatal asphyxia is the most important preventable cause of newborn death and morbidity. And what is perinatal asphyxia? It is the damage to the baby's body because of lack of oxygen. And it contributes to 20% of newborn death. A newborn resuscitation program is the most effective tool to reduce perinatal asphyxia. And newborn resuscitation program is a standardized, structured program which brings an updated evidence-based practice. So this is a simplified algorithm. So if you ask if the baby is crying, not crying, then go for initial step, clamp the cord, umbilical cord, cut it immediately, bring the baby to the warmer, provide warmth to the baby, and then clear the baby's airway secretion, dry and stimulate. So within 30 seconds, you should complete this step, which is called the initial step, and see the heart rate and the breathing. If the baby is not breathing or gasping or heart rate less than 100, then you go for the second step, which is a breathing step, that is providing positive pressure ventilation with the saturation monitoring. Now, if the heart rate after 30 seconds of positive pressure ventilation, if the heart rate is less than 100, if the heart rate is less than 100 and not rising with positive pressure ventilation, then you have to do the ventilation corrective step. And after ventilation corrective step, after giving effective ventilation for at least 30 seconds, still the heart rate is less than 60, then you go for chest compression, in which case you have to intubate the baby and coordinate with positive pressure ventilation. And after 60 seconds of chest compression and coordinated positive pressure ventilation, if still the heart rate is less than 60, then you go for IV adrenaline. And if the baby's heart rate is still not improving, then you should consider hypovolemia and give normal saline bolus or pneumothorax, in which case you have to drain the pneumothorax. And now initially, if the baby is breathing, but the baby is having persistent central cyanosis or labored breathing, then you can go for CPAP. And CPAP is continuous positive airway pressure. Now, if the baby was crying initially, then you go for routine care. And routine care means the provide warmth, keep the baby on the mother's abdomen, and provide warmth, clear the airway dry, and remove the wet linen and clamp the cord after 1 minute. This is called delayed cord clamping. This is the target saturation which you target for each time interval. And this is again the same thing, the resuscitation program, which starts with preparation before delivery, then where you discuss the umbilical cord management also as per the new guideline, and then you have the initial step, the positive pressure ventilation, chest compression, adrenaline, and then if it is not improving, then you should consider hypovolemia and correction of pneumothorax. So let's go to the equipment. What all equipments you should need prior to the delivery. Before the equipment, you should ask the obstetrician what is the problem. So is the baby preterm or term? Is there multiple gestation twins or triplets? And is there meconium stained amniotic fluid? If the mother has any complications like blood pressure, diabetes, etc. Now, and the equipment to be kept ready can be again remembered as TABCD, which is temperature, airway, breathing, circulation, drugs. The temperature you need the warmer, the warm blanket, and airway you need the laryngoscope, the endotracheal tube, the suction tube, and then the breathing you need the bag and mask, the flow inflating bag, the self-inflating bag is the most commonly used device, and then TP's resuscitator, especially if it's a preterm baby, then the pulse oximeter definitely. For airway, you should also consider laryngeal mask airway, LMA for one size. And then for circulation, you need your hands, and for drugs, you need adrenaline and umbilical vein catheter with flush. So these are the equipments that you keep ready. First is temperature, where you keep the warm blanket, the preheated warmer. Then you need to manage the airway, where you need the suction, and you need the laryngoscope, endotracheal tube, the laryngeal mask airway, then the oxygen, the pulse oximeter, then the bag and mask, and the stethoscope definitely to know the heart rate, and the umbilical vein catheter, then the adrenaline, normal saline. These are the equipment. So the necessary equipment should be assembled. The radiant warmer is kept on. The oxygen source is open with adequate flow through the tubing, and then the suction catheter is functioning properly, set at 100 millimeters of mercury, and then laryngoscope is functioning, and the resuscitation bag and mask is functioning, or the pressures of the TP resuscitator is set. Now, no longer optional. So these are the following equipments which are now no longer optional, but it should be available for every birth. So first is the compressed air source, so that it can give a fraction inhaled oxygen of 21%. Second is oxygen blender to mix the oxygen and the compressed air with a flow meter. And third is pulse oximeter for neonatal use, oximeter probe, which is available at every hospital, and the laryngeal mask airway with size 1. So what you should ask the obstetrician. So like I've already told you, whether the baby is preterm, term, whether there is twins, triplets, what is the whether it is amniotic fluid is meconium stained, And definitely umbilical cord management. If the baby is not crying, then early cord clamping, cutting, and if the baby is cried, then keep the baby on mother's abdomen, especially if the baby is more than 34 weeks or term. So these are the factors associated with high-risk delivery, that is the age of the mother more than 40, less than 16, poor socioeconomic status, detrimental drug addiction, smoking, alcohol abuse, diabetes, hypertension, chronic heart, lung disease, kidney, urinary tract infection, blood disorders, and obstetric conditions like prior stillborn, prior birth of high-risk infant, antepartum hemorrhage, premature obstetric membrane, infections, chorioamnionitis, and placental anomalies like placenta previa, polyhydramnios, oligohydramnios, PIH, then fetal conditions like prematurity, post-maturity, intrauterine growth restriction, macrosomia, multiple gestation, congenital anomalies, hydrops, and during birth like complication of maternal medical disease, preterm labor, collapsed umbilical cord, uteroplacental bleeding, and abnormal presentation, and abnormal fetal heart rate pattern, instrumental delivery, C-section for maternal or in fetal compromise, and narcotic administered to the mother. And at the time of birth, note the time and receive the baby in a dry, warm linen. And suction after birth should be done only if it is needed, uh, and uh, and see whether the baby is breathing. If the baby is breathing, the tone is good and the term, then keep the baby on mother's abdomen, provide warmth and assure open airway, dry and stimulate the baby, and cut the cord after 1 minute. So actually no need for stimulation, just dry. And remove the wet cloth, cover the baby with dry cloth. And if the baby is not crying or breathing, then go for initial steps that clamp and cut the cord immediately and place the baby under radium warmer, dry and stimulate and position and clear the airway if needed. So this is the step for the pre-delivery questions and the initial step. So the pre-delivery questions are whether baby is preterm or term, meconium chained, and any other additional factors, and umbilical cord management. So prepare the team and team debriefing, and check the equipment, functioning of ambu bag, laryngoscope, then availability of endotracheal tube, suction tube, pulse oximeter. Then cord clamping should be delayed at 60 seconds, and functioning of ambu bag is assessed by squeezing the bag with a palm covering the mask, and with airtight seal around the mask. Pop-off valve opens and makes hissing sound. Feel for the air or the pressure against the palm, and this ensures opening of the fish mouth valve, and the bag should recoil instantly when the pressure is released. Now, assess for the breathing or crying. The baby is breathing and crying, and turn baby, deliver baby to the mother's abdomen, and give skin-to-skin contact, dry and baby, and remove the wet linen, cover the baby with warm towel, delayed cord clamping, initial breastfeeding, and baby and mother to be in skin-to-skin contact. If the baby is not breathing, then initial steps that clamp the cord and cut the cord immediately, shift the baby to warmer, dry, and replace the wet linen with another pre-warm towel, and stimulate and place the baby in sniffed-out position and suction the mouth, followed by the nose. And after the initial step, assess the heart rate and the breathing. If the heart rate is less than 100, and if the baby is not breathing or gasping, then go for positive pressure ventilation of second step. If the heart rate is more than 100 and the baby is breathing and appears sinus, check for saturation. Saturation is below target, then we can give free flow oxygen. If the baby is labored breathing and nasal CPAP, then you can consider nasal CPAP. And meconium chain amniotic fluid does not influence the resuscitation. This is the sniffed out position that is slightly extended. The baby's neck should not be flexed or hyperextended. And this is the way how to stimulate the baby. If the baby is not breathing, the best way is to rub the back of the baby with a hand or a cloth. And if the baby after initial step is still not breathing or gasping, heart rate less than 100, then you give initial positive pressure ventilation using room air if the baby is term, and check the heart rate after 5 inflations. You can give the positive pressure ventilation using the self-inflating bag and mask, or using the flow inflating bag and mask, which is not used in our setup. And then if the baby is preterm or even if term, you can use the TP resuscitator. Now, if still the heart rate is less than 100, assess the chest rise, ensure the airway is open, reduce leak, and increase the pressure. So that is called the MR SOPA, which is the ventilation corrective step. Now we have come to the positive pressure ventilation step, and that is the breathing. The second step is to give effective positive pressure ventilation, and you have to initiate the positive pressure ventilation with the self-inflating bag. And the mask size should be 0 or 1, and place the mask covering the chin to the bridge of the nose and provide the airtight seal and give positive pressure ventilation for 30 seconds. If the baby is more than 35 weeks gestation, then give FiO2 21 to 30%. If the baby is preterm, less than 35 weeks, then you give FiO2 of between 21 to 30%. So if the baby is term or more than 35 weeks, then you resuscitate with room air. If the baby is preterm, less than 35 weeks, then you give resuscitate with FiO2 between 21 to 30%. The rate of positive pressure ventilation is between 40 to 60 per minute, and for that you will say loudly, breathe 2-3, breathe 2-3, and give breathing. Now the rate of the assistant, the role of the assistant is to find out whether the positive pressure ventilation is effective, which is to see whether the chest is moving and whether the heart rate is increasing. Now the assistant connects the pulse oximeter to the right hand, and after 15 seconds look for the effectiveness of positive pressure ventilation. Now if the positive pressure ventilation is not effective, then you do the MR SOPA. MR is done first, that is mask is readjusted and reposition the head and neck for neck dog position. Give 2 breaths, no chest rise. Go for the second, third, and fourth step, that is suction of the mouth and nose, and then open the mouth and give 2 breaths. And if no chest rise, then increase the pressure, and again give 2 breaths, no chest rise. Then go for alternate airway, which is intubation or laryngeal mask airway. After that, give 30 seconds of effective ventilation and assess the heart rate. If the baby's heart rate is less than 100, continue positive pressure ventilation. If the baby's heart rate is more than 100, but not breathing, then continue positive pressure ventilation. If the baby is breathing well, heart rate is more than 100, then you can reduce the rate of positive pressure ventilation and stop it. Now, type of care depends on the duration of positive pressure ventilation. If the positive pressure ventilation is more than 30 seconds, then you go for observational care. Now, if the baby more than 30 seconds, then go for post-resuscitation care. If it is less than 30 seconds, then you can keep the baby to the mother's side and monitor for the heart rate and the breathing every 15 minutes in the first hour and every 30 minutes thereafter in the second hour. So this is the mask position. It has to be placed on the mouth and the nose, and this is how you hold the mask against the mouth. That is the easy clamp, and the C is the thumb and the index finger, which holds the mask, and the E is the remaining fingers, which holds the mandible, and thereby creating a perfect seal. And this seal helps prevent the leakage of air. So this is called the EC clamp. So the hand is positioned so that the ring and the middle finger are spread over the mandible, and the thumb and the forefinger forms the C, and the mask is squeezed on the face, and the seal is formed between the mask and the face. So the indication for positive pressure ventilation is heart rate less than 100, baby is not breathing or gasping, and persistent central cyanosis and low oxygen saturation despite free flow oxygen increased to 100%. So when the positive pressure ventilation begins, they assess the rising heart rate and improvement in oxygen saturation. If not evident within 5 to 10 breaths, ask the assistant to assess the bilateral breath sound and chest movement. Now, use the pulse oximeter. When the resuscitation is anticipated, you should keep the pulse oximeter ready. Positive pressure ventilation is required more than a few breaths. You connect the pulse oximeter. Central cyanosis is persistent, and you need to confirm your perception of central cyanosis. And when you use supplemental oxygen, so these are the indications of pulse oximeter. Now coming to the target saturation. At 1 minute, you target saturation of 60 to 65%. At 3 minutes, target saturation 70 to 75%. At 5 minute, target saturation between 80 to 85, and at 10 minutes, target saturation at 85 to 95. This is the ventilation corrective steps, and MR SOPA means mask adjusting and reposition the head in sniffing position, And then SO means suction the airway, first mouth and then nose, and open the mouth, baby's mouth. And P means increase the pressure, and A means alternate airway, which is intubation or laryngeal mask airway. Now, the indication for endotracheal intubation is meconium strained amniotic fluid and baby is depressed, or positive pressure ventilation not resulting in good chest rise despite all the other previous steps, or need for positive pressure ventilation for more than 1 minute, or need for chest compression, or congenital diaphragmatic hernia. So this is the positive pressure ventilation via endotracheal tube, and we have already discussed the indications. And coming to the size of the laryngoscope straight plate, we use straight plate, and size 0 is for preterm and size 1 for term baby. But in our hospital, we use size 00 for preterm and size 0 for term babies. An endotracheal tube of sizes 2.5 for weight of less than 1 kilo, 3 for birth weight of 1 to 2 kilo, and 3.5 for weight of more than 2 kilos. Because we don't take weight before resuscitation, we take the ultrasound weight to determine what is the endotracheal tube size needed. The endotracheal tube insertion. The laryngoscope blade is introduced into the mouth and manipulation is done to visualize the vocal cord. The endotracheal tube is inserted and checked for its endotracheal tube position, and by witnessing the increased heart rate or chest rise with positive pressure ventilation, and the procedure should be done within 30 seconds. Endotracheal intubation should be done within 20 to 30 seconds. And assess the heart rate. If it is more than 100 and baby is breathing, send the baby for post-resuscitation care. If the heart rate is between 60 to 100, continue positive pressure ventilation. If the heart rate is less than 60, after 30 seconds of positive pressure ventilation, then you go for chest compression. So this is the table showing the endotracheal tube size with respect to the various weight: less than 1 kilo, 2.5, 1 to 2 kilo, 3 size, and more than 2 kilo, 3.56. This is the tube size with respect to the baby's gestational age, and this is the use of laryngeal mask airway for the baby. It can be, it should be one size tube, and after inserting, you would inflate the balloon at the laryngeal inlet. And if the heart rate is less than 60, despite 30 seconds of chest compression, and then you go for chest compression. So for that, you continue positive pressure ventilation with 100% oxygen and start chest compression with a ratio of 3:1, 3 chest compression and 1 breath. So chest compression is done with two-thumb technique, which is the better way compared to two-finger technique. So two-thumb technique is better than the two-finger technique. So indication for chest compression is intubation is the heart rate less than 60 per minute despite 30 seconds of effective ventilation. Then you intubate. If not done early, connect to 100% oxygen and call for help and position the chest. Chest compression is done from the head end after intubation, so that the area of the abdomen is free for umbilical cord insertion, the catheter insertion. And the ratio of positive pressure ventilation to chest compression is 1:3. So for that, you say loudly, coordinate the positive pressure ventilation chest compression by saying loudly 1 and 2 and 3 and breath, and 1 and 2 and 3 and breath. And the depth of insertion, depth of chest compression is 1/3 of the anteroposterior diameter, and the location of giving chest compression is the lower third of the sternum, but above the sternum. Now, after 60 seconds, if the heart rate is more than 60, then you stop the chest compression and continue positive pressure ventilation. If the heart rate is still less than 60, then you check for any problem in delivering chest compression, that is cardio. Now, cardio is a mnemonic to remember: C for chest movement with positive pressure ventilation, A for airway is correctly intubated, and R for rate of coordinated positive pressure ventilation with chest compression, which is 1:3, and D for depth of chest compression, and IU for fraction inhaled oxygen of 100%. Now, if the heart rate is not detected and it continues to be less than 60 despite 60 seconds of coordinated positive pressure ventilation and chest compression, then you give adrenaline with a dilution of 1 in 10,000 at a dose of 0.2 ml per kilo. And if you are using endotracheal route, then you can give at the dose of 0.5 ml per kilo. Now, the recommended route is IV, which is umbilical vein, and consider endotracheal only if IV access is not available. And epinephrine dose may be repeated every 3 to 5 minutes. This is a step for umbilical vein catheterization. You tie the cord and then you insert a flushed catheter and then you fix it by adhesives. So you have to clean the base, prepare with antiseptic solution, and then you tie the umbilical cord and you cut the cord, and then you insert the pre-flushed umbilical catheter into the cord at least 4 centimeters, 3 to 5 centimeters, and check for blood return. And once the blood return is there, you secure the catheter by manually or by addition. Now, the medication used is adrenaline, which is 0.2 ml per kilo, 1 in 10,000. And if the baby is, if you are giving endotracheal, then you give 0.5 ml per kilo. And normal saline is given 10 ml per kilo if the baby is in shock. And this is the fourth step, that is the drugs. And if the heart rate is less than 60 despite cardio, then you give adrenaline. You can repeat every 3 to 5 minutes at a dose of 0.2 ml per kilo, 1 in 10,000. And if you are using endotracheal route, then 0.5 ml per kilo. Now, if after 60 seconds of chest compression and positive pressure ventilation and giving adrenaline, if still the heart rate is less than 60, then you have to go for rule out other things like shock or a pneumothorax, hypovolemia or pneumothorax, in which case you have to give a bolus and 10 ml per kilo. And pneumothorax, you have to drain it using intercostal drain using 3-way stopcock and syringe. If there is no response to adrenaline, then continue. You can consider discontinuing the resuscitation after 20 minutes. Post-resuscitation debriefing and family should be counseled. Now, if the baby's breathing and heart rate picks up and it is above 100 breaths per minute, then you shift the baby to the NICU for post-resuscitation care. Now, if positive pressure ventilation was given for less than 1 minute or 1 minute, then you can keep the baby with the mother, that is observational care, and you monitor the vitals. If the positive pressure ventilation was given more than 1 minute, then you shift the baby to the NICU for post-resuscitation care, but 30 seconds to 1 minute. Now, if the meconium, if the liquor or amniotic fluid is meconium stained and the baby is vigorous, then continue with the routine care. Now, if the baby is depressed, and then proceed with resuscitation and baby to be admitted in an ICU observed for respiratory distress. Now, when to stop resuscitation? So it was initially 10 minutes. Now it has been extended to 20 minutes of no heart rate. Withholding resuscitation can be done for less than 23 weeks, and in Indian setup we go for less than 25 weeks. Then presence of anencephaly and trisomy 13 syndrome, that is the Petau syndrome. Now, babies born between 25 to 28 is increasing in developed countries, but may not be true for most part of our country. So we also have 25 to 28 weeks, and a lot of good NICUs are coming up where these babies are getting saved. And preterm babies. So risk factors for preterm babies increase heat loss, and there is damage to immature tissues, and then there is ineffective breathing and apnea, and difficult ventilation because of RDS, respiratory distress syndrome, then increased risk of infection, then intraventricular bleed, and hypovolemic shock. So the precautions you take for preterm babies: increase the temperature of the delivery room to 26 degrees Celsius, preheated linen, food-grade plastic wrap for early preterm less than 32 weeks, blended oxygen and TP resuscitator, and transport incubator pre-wound. Now, minimizing the neuronal injury can be done for preterm babies can be done by gentle handling, avoiding head-low position, avoiding excessive pressure while giving positive pressure ventilation of CPAP, then using blender and pulse oximeter to avoid oxygen toxicity and avoid rapid infusion of fluids. Post-resuscitation care for preterms is by monitoring for apnea and bradycardia, use of oxygen ventilation judiciously, initiating IV fluid or enteral feeding, monitoring the blood sugar, and ruling out infections and preventing infection. And neonate with persistent bradycardia and or hypoxia despite effective ventilation, think of conditions where there is a problem with lung function, like a pulmonary hypoplasia, congenital diaphragmatic hernia, pleural effusion, or pneumothorax. Now, what is congenital diaphragmatic hernia? The herniation of intestine into the thorax. So, no bag and mask should be given because it can result in distension of stomach and intestinal content, and that can compromise ventilation. So, immediately intubate and give positive pressure ventilation. Feeding tube is to be inserted to decompress stomach and the bowel and more, and they are more prone to pneumothorax. So, we must do gentle ventilation. So, and special consideration is babies with choanal atresia, where you place a plastic oral airway to allow air to pass through the mouth. And one technique is called the McGovern nipple, which is a nipple with a hole and then placed over the baby's mouth. Then the Pierre-Robin sequence, Pierre-Robin syndrome or sequence, where you have to place a nasopharyngeal airway so that the baby can be nursed in prone position so the baby can breathe. So these are the various situations, special situations. One is the preterm, which we have already discussed, and persistent bradycardia despite effective ventilation, where it can be severe asphyxia or congenital heart block. Not improving and sudden worsening can be a lung problem like pneumothorax and pleural effusion. Not improving with resuscitation can be again diaphragmatic hernia, lung hypoplasia, PPHN. Chest is not moving despite endotracheal intubation can be an obstruction in the airway, where you use rarely tracheal aspirator, which was previously commonly used during meconium stent amniotic fluid, meconium aspiration. And here only in rare situations. And you remove the endotracheal tube with suctioning and do not move to the next step until chest movement is seen with positive pressure ventilation. So if there is no spontaneous breathing, then it can be severe asphyxia or neuromuscular disorder or CNS malformation, and resuscitation sequence is no different. Airway malformation suspected like Pierre-Robin or a mass in the lower jaw, that is cystic hygroma, then you will need to put the nasopharyngeal tube, that is using a 2.5 size ET tube. And exit procedure, this ex utero intrapartum therapy may be also needed in such babies. And then babies with choanal atresia, where you put the oral airway. The babies with gastrochisis and omphalocele, you have to clamp the cord very far, as far as possible, place the baby and the exposed bowel in a sterile clean plastic bag and position the baby and the bowel on the right side and insert the feeding tube for gastric drainage. If the baby requires positive pressure ventilation with gastrochisis, then intubate is preferred over bag and mask. Neural tube defect, meningomyelocele, the baby is placed in prone or lateral position, and if the baby needs resuscitation, place a donut using towel and place it at the level of the lesion to avoid the pressure effect on the lesion due to the body weight. Use a non-latex plastic wrap over the lesion. Now, infection prevention. Hand hygiene is important. Then the linen and the cap should be clean. The warmer should be clean, and the self-inflating bag should be sterilized. And the laryngoscope should be sterilized. Now, therapeutic hypothermia is used if the baby had asphyxia, a baby is more than 36 weeks, and the baby is born within 6 hours of life. This is a simplified algorithm which I have already shown you. This is a nutshell. NRP nutshell. Again, I am reiterating there are only 4 steps, and if the baby is not breathing, then you go for initial step where you dry and stimulate, clear the airway and the position. After 30 seconds of initial step, baby is not breathing, go for positive pressure ventilation or give breath. And the third step, if the baby is not having heart rate less than, if the baby is having heart rate less than 60 despite 30 seconds of effective ventilation, go for chest compression. And the final step is the drugs where you give adrenaline. If the heart rate is less than 60, persistently less than 60 despite chest compression and positive pressure ventilation. And this is the 8th edition. So let's see what all changes have come in the 8th edition of the NRP. They have added the umbilical cord management. Apart from checking for the preterm, the amniotic fluid, and additional risk factors. So umbilical cord management. And then second thing is initial step almost remains same, and it has gone in a sequence: warm, dry, stimulate, position airway, and suction if needed. And third is when an alternate airway becomes necessary, a cardiac monitor is recommended. Cardiac monitor, ECG. And fourthly, flush the IV or intraosseous epinephrine with normal saline applies to all weight with 3 ml of normal. Adrenaline dose has been fixed at 0.2 ml per kilo 1 in 10,000. And if the heart rate is not there, then you can continue till 20 minutes before stopping. So the umbilical cord management recommendations are for term babies more than 34 weeks or term resuscitation, the delayed can be done more than 30 seconds or 1 minute. If for preterm babies who do not require resuscitation, delayed cord plan can be done. But between 20 to 34 weeks, who do not need resuscitation, again, intact cord milking can be done, and delayed cord clamping cannot be done. And less than 20 weeks, intact cord milking is also not recommended. And positive pressure ventilation TPs resuscitator or instead of self-inflating bag for newborn babies, particularly for preterm babies. And the positive pressure ventilation interface may be reasonable to use supraglottic airway or LMA. So thank you for your patient listening, and this is the presentation on neonatal resuscitation, and I hope you understood the NRP.